Today I'm going to show you guys how to insert an NG tube. So the first thing that we're going to do is we are going to check our order. We'll check our order in CERN. We'll make sure that we have the right patient. We've got Mr. Mark here. We'll make sure that we'll check his armband, make sure that the order is for what we're doing. So we're going to insert an nasogastric tube. Some of the reasons that we might do this may be bowel obstruction. It could be the patient can't eat, has a problem with swallowing. Could be a gastric bleed. So for whatever reason, just make sure that we've got everything straight and that we're doing it on the right patient, of course. Now, we're going to gather some equipment. One of the first things that we're going to get is a 60cc syringe. There are a couple of different syringes that you can get. A bulb syringe is one of the more common ones. You can also get this catheter tip. It's a 60cc. A lot of people call it a chew-me syringe. This is the one that I prefer personally. So this is the one that you'll see me use today. Obviously, you need the NG tube. If it's a GI bleed or something with larger particles, you may need a larger French, like maybe an 18 or a 16, just kind of depending. If you think it's going to be a lot of fluid, maybe you could do something a little bit smaller. But if you're not sure about it, just consult the physician and see what size that you want. I need some tape. I also need my suctioning extension. I'm going to take this, I'm going to hook it up to my suction and get my suction prepared. So we will take the suction. You can use wall suction or portable suction, and we're going to hook up the vacuum to the vacuum that goes to the wall, and then we're going to hook up the tubing to the patient side. Okay, we're just going to make sure that this works before we start. And we can turn it back off and have it ready. And we are also going to get, this is a skin prep, you can get benzoin, the benzoin bullets, because at the end we're going to take this NG tube to the nose so that it stays in place. We also have the NG tube anchors that you put to the nose and it clips. So either one of those is going to be appropriate. And then of course we need a stethoscope and just an emesis basin just to try to help keep stuff clean along with the washcloth. So I'm going to talk to the patient. I'm going to explain the procedure to him. Mr. Mark, we're going to insert a tube that goes into your nose, goes down into your stomach so that we can suck out all that stuff that's in your stomach. Now, this can be an uncomfortable procedure. The other thing that you want to get from the physician is maybe an order for lidocaine or some sort of lidocaine spray for the mouth and for the back of the nose. So when we go through this, sir, I'm just going to have you lean your head forward and sit up straight. And while I'm putting the tube in your nose, once it gets to the back, I'm going to have you start to drink some water, if that's at all possible, okay? So I've talked to the patient, I've kind of prepared him. The next thing I'm going to do is put my gloves on, which I don't have gloves today, but obviously always wash your hands, put your gloves on. I'll get the tube out. Now sometimes what you can do with these NG tubes is you can kind of bend the end a little bit. It kind of helps it get the right curve. And then I have my KY jelly here. And you can open this up and squirt your KY jelly into here and put it on your tube. So positioning is very important for an NG tube. Of course, when we do airway, we always want the head in a sniffing position. So for an NG tube, it's going to be the exact opposite. You want the chin to the chest. Obviously, if there are no contraindications, meaning no spine injury, no reason that they can't move their head forward. So I'm going to have Mr. Mark, I'm going to have you move your head forward, chin to your chest, as much as is comfortable, okay? Now, you're going to just choose which nose you're going to do. I usually just always do the right because it's closest to me. But obviously you would check that if the nose is occluded or if there's some sort of trauma, then you're not going to use that one. So I'm going to start the insertion of the tube. Now with the tube, you're just going to go straight back. And as you go in, if you rotate, sometimes it can help. When you get to the back of that nasopharynx, you'll feel a little bit of resistance. Don't be afraid of that. You kind of have to twist it and push through that. This is also the point which you will have him take his water. And he will start to sip this through his straw, okay? And he'll have to hold that up. You may have somebody come help you if you think it's going to be too difficult for them. But as long as there are no contraindications, he can start to drink some water, and that action will help the NG tube go down the right part of his nose, okay? The next thing that we're going to do is take this NG tube, we're going to measure it. Now, the gold standard way usually to measure it is from the nose to the ear to the xiphoid process. Now, you can look at the mark at 45, see where it's at. I never remember that, so usually the best thing to do is take a little piece of tape, which I've already got cut off here, and put it right there, okay? Okay, so we're going to keep inserting. The patient's going to be very uncomfortable, but what I want you to understand is that the patient starts to have desaturation in oxygen. We would have a pulse ox on him. If his oxygen starts to go down, if he starts to cough, if he gets really blue in the face, just pull it out and reinsert it, okay? This is going to be uncomfortable, but he should be able to swallow. He should be able to talk to you if he's, not choking up too much. So we've got it down to where the tape is measured. So the next thing we're going to do is assess the patient, make sure his oxygen level's good, make sure he's not in any distress. Of course, we dealt with the tube to go down to the lung, right? So we want to make sure it's in the stomach. So the next thing that we're going to do is check it. Now on the end, we have our connector that comes with the NG tubes. So we'll put that on the valve that lets the air out. We'll take anywhere from 10 to 30 cc's of air, and we'll put our stethoscope on, and we will listen over the stomach. Okay. And I will hear an air bolus over the stomach. Now, another way that you can check it is check the pH of the gastric contents. Rush Hospital's policy is to get a chest x-ray, and you never want to put any kind of feeding tube or anything like that before this is confirmed in the stomach. So usually you are going to insert these for NG tube or bowel, or not NG tube. Usually you're going to insert these for bowel obstruction or GI bleeding, which a lot of times they will go to intermittent suction. So once we've got that in there, we can take it and hook it to our suction. Okay, we have a little extension tube on here, and then of course we turn it on back here, and you're going to usually turn it on intermittent. You want to make sure that it can release from the stomach, and you do it on a low intermittent suction is what's most common. And then of course our assessments are just going to include to make sure that what color our drainage is, at what depth we inserted the NG tube, confirm placement, all those things need to be charted in Cerner, and then just do your regular assessment data every 6 hours if you're on med surge. So the last thing that we're going to do is obviously make sure this is secure in place. Now, like I said, you do have the NG tube holders that are commercial, but if you don't have one of those, you can take your skin protectant or take your benzoyl bullet, wipe the nose, take your piece of silk tape. Usually the easiest thing to do is rip it down the center, put it on the end of the nose after that dries, and you're going to wrap it around in this manner, okay? And then you just want to check that tape, make sure that the patient is not getting any breakdown or anything with your every 6 hour assessment on the floor, okay?